much, Priya, for that introduction. And welcome everyone and good evening to this case presentation, which is in an effort to help us to an approach to an abnormal liver function test. So this case was an interesting case. A few weeks ago, I got called by a GP about an 84-year-old patient with deranged liver function tests, an elderly female patient. The patient had slightly icteric sclera and a tinge of jaundice to her skin on presentation to the GP. She also had a tender right upper quadrant. This was an acute presentation being of a few days in duration, and according to the GP, she had no significant drug, alcohol, or medical history, except she was a type 2 diabetic on valproic acid low dose for diabetic peripheral neuropathy. The GP further said that her ultrasound liver showed a homogeneous echo texture with no diffuse masses noted. At this point, he shared her baseline results that he did as a GP in his rooms. This basically showed an elevated liver enzymes across the board, with the T-bill about 3 times upper limit of normal, direct to conjugated bilirubin about 7 times upper limit of normal, ALK phos being slightly above upper limit of normal, gamma GT being 4 times or more upper limit of normal, and a florid increase in your transaminases, which were about 10 to 15 times upper limit of normal. At this point, given her elderly age as well as her signs and symptoms, she was encouraged to be admitted, and the doctor did consult with the physician to this end. The physician in Hillcrest agreed and admitted the patient and did further investigations. Then the circle investigation shows the liver function tests, and as we said, we went through the initial panel of results. There was a slight flare-up in the ward, as you see on the 9th of September, with her T-bill going up to 91 and her D-bill to 44. Over the next few days, however, her enzyme levels across the board settled quite nicely. And she was managed symptomatically and supportively at this stage with IV fluids, and she was investigated as to the cause of the increase in the liver enzymes. The other investigations that were done from a biochemistry perspective was albumin, which, as you see, was decreased albumin, which is very common in chronic liver disease. The globulins were increased, which is a hypergammaglobulinemia, often occurs as infection or in chronic liver disease. At this point, the physician chose to screen for hepatitis B, and I'm going to leave this to my microbiology compatriot to unpack for you, to show you the surface antigen, the negative surface antigen and what that means, as well as the antibodies. The physician was then guided by our microbiologist, Dr. Shailen Pillay, who you will meet later, and he also excluded hepatitis A. And as you can see, the IgM was negative, which means negative current infection, and the Hep A IgG was positive, which means past infection. She did not have any gastroenteritis symptoms, which is often found in Hep A. However, the physician thought this prudent to exclude. He also thought about the differential of autoimmune hepatitis, especially in an elderly female. And lo and behold, the ANA was positive in a high titer of 1 in 320, and it was a speckled pattern on IFA. This is a diagram on the right showing how the IFA pattern's immunofluorescent assay looks under the microscope, and that would be a speckled pattern. Just for us to remember that an ANA is nonspecific, and a 1 in 320 or higher often goes to a further investigation of an ENA screen, and a speckled and homogeneous picture is often nonspecific. The ENA screen was performed, and it was positive as well, and it was 1.5, the quantitative value. The further breakdown of the autoimmune results showed ribonucleic protein or Smith ENA profile of equivocal, the Rho52 ENA profile equivocal. The smooth muscle antibody was positive in a titer of 1 in 80. We'll come back to this later, but you often find in autoimmune hepatitis the smooth muscle antibody being positive, so this further supported the diagnosis. The Smith ENA profile equivocal and the Rho52 is also very nonspecific and found in many autoimmune conditions. With regards to this patient, our microbiologist discussed it with the physician and encouraged the PCT because, as you saw, only a CRP was initially done, and that was less than 100, which just showed generalized inflammation. The patient was then hospitalized as per what the physician saw fit, and he did a blood culture and sputum MCNS, as the patient was also dyspneic on arrival. She was started on IV Rocephin empirically while they waited for the sputum MCNS and the blood culture. And he did a CT chest to exclude a pulmonary embolus as the D-dimer was high in presentation. The CT chest did not show any wedge infarct or pulmonary embolus. It did show basal atelectasis, and there was no embolus, thankfully. Over the time in the ward, her dyspnea improved, and the blood culture and sputum MCNS was then found to be negative. The markers of inflammation and sepsis subsequently dropped and improved in the time, and she was discharged after the course of Rocephin. So the physician at this point came up with a differential. Is this autoimmune hepatitis with an exacerbation due to sepsis, but what was the source of sepsis? Or is this a viral hepatitis, which was not one of the ones we tested for? Remember, he tested for Hep A and Hep B on a background of autoimmune hepatitis. It's very common in females. And this viral hepatitis that we had not tested for was running a self-limiting course. Because remember, she was discharged quite well. I will now hand you over to my colleague, Dr. Shaylin Pillay, to discuss an approach to the infectious etiologies of hepatitis. Thank you.
Good evening, everyone. All of the blood in our body is filtered through the liver, and the liver performs over 100 functions. So, in considering infectious etiologies of hepatitis, the status quo is very much to go viral. One typically considers hepatitis A, B, and maybe hepatitis C. Why not? I myself do advocate that this is indeed a good place to start, because common things do occur commonly, right? But just how commonly? In 2022, the World Health Organization reported 3,500 deaths per day attributable to hepatitis B and C. In the same year, 6,000 people were newly infected per day with viral hepatitis. Viral hepatitis, as you know, encompasses a spectrum of expression ranging from asymptomatic, acute, a rarity is fulminant infection. It can be chronic, and in the case of B and C, it can cause cirrhosis and hepatocellular carcinoma, also contributing to millions of deaths globally. However, especially in under-resourced settings, it is underdiagnosed and undertreated, yet there remains very high impact interventions for this entity. So yes, indeed, it is a good place to start and to go viral. However, in appreciating this slide, consider how very broad the umbrella of infectious etiologies of hepatitis really is. What you see here may look like an exhaustive list. However, it is by no means fully a comprehensive hit list. So the usual go-to viral suspects, which I've highlighted in blue on your left, are the hepatotropic viruses. They have a tropism for the hepatocytes and they cause liver damage primarily. And this is in contrast with other infectious agents that may be contributing to hepatitis, but where the liver may just be collateral damage of another primary pathology. While lab medicine is certainly progressing marvelously with the battery of tests at your disposal, it remains very important to exercise judicious use of such services to mitigate unnecessary costs and to focus your investigation so that you select those that are most impactful and add the most value to your clinical decisions. It's ironic then, in reviewing these lists, that it is the history that is often the missing element that provides most insight into the likely cause. So in conjunction with your history, you would need to consider occupational history, travel history, recreational and environmental history, habits, and this would also be to often gauge for vector contact in your more ARB causes, and you will marry this with patient demographics, the clinical findings, radiology, biomarkers, and other lab indices. So if we progress on our viral list, at the end of March 2022, there was an outbreak of a hepatitis of unknown origin, first reported in Scotland. By the end of May, more than 700 cases were reported in over 36 countries, over 4 continents, and this was in children. There was 1 fatality and 10% required liver transplants. So many of these cases were actually associated with a specific adenovirus serotype, and some also SARS-CoV-2. A survey done in 2018, a survey done looking at 218 human cases ID'd chicken consumption in 48%. If we look into the bacterial box and you see that little picture of chicken next to Campylobacter. So Campylobacteriosis is one of the leading causes of diarrhea worldwide. And you know, if the patient, for example, has gastrointestinal symptoms of emesis, or typically it's diarrhea, acquired through ingestion of contaminated food, undercooked chicken, even vegetables that's prepared on the same chopping board can be a culprit. And it takes a very low inoculum to cause disease, and it may progress to hepatitis. So in me leading you to the bacterial causes, just know that any bacterial cause of sepsis, when it is overwhelming enough, can lead to hepatitis. So if you look at the rat, that is alluding to leptospira. So leptospirosis is a zoonotic disease, much like malaria, Bartonella, also on that list next to the cat. It is a helically wound bacteria that causes infection in animals. Humans are an incidental host, and 90% will have mild symptoms. However, in that 10%, life-threatening disease can occur, including a very severe hepatitis. And I just enumerated that because it is endemic to sub-Saharan Africa. There's a mortality of 5 to 10%. There can be a pulmonary element, and according to the NICD, over 1 million cases are reported per year. So there's Q fever to consider, there's rickettsia, you see the bunt tick there, the amblyomma tick, found in cattle and game. Obviously, if the history fits, if an eschar is noted, a small dark brown black scab surrounded by inflammation, it can hide in between toes and the hair and the skin folds, can be confused with the spider bite. If there's any element of diarrhea and walking barefoot, exposure to fresh water, you would think of things like schistosomiasis. There's the liver fluke, fasciola, travel history with malaria. So this is just to emphasize the point of how important a history and how valuable a history can be. So if we take stock of that and if we reflect on our patient, why I recommended the blood culture and other septic markers, I will unpack now. And also the patient did have pulmonary symptoms, hence the sputum MCNS. If there was any element of diarrhea, a stool MCNS, there are also stool PCRs that could be done. So while blood cultures are the gold standard to diagnose bacterial sepsis, there is a delay in turnaround time. There may be false positives and negatives, as a patient may not always be continuously bacteremic. So every hour delayed in starting appropriate therapy for sepsis, there's a 7% increase in mortality. So this is where the value of septic markers may come in, and particularly the PCT or procalcitonin. It is more sensitive than a CRP, and it can be used to differentiate bacterial sepsis from non-infectious systemic inflammation. So PCT levels are also raised earlier during the infective process versus CRP, and it can also be used as a prognostic marker in bacterial infection in terms of judging bacterial load and severity of infection. And multiple RCTs done in ICUs have shown that when PCT is used in conjunction with clinical improvement, in the arm that it was used for, antibiotics can be stopped earlier, patients can be discharged earlier, and mortality is less. So in this case, for example, where the PCT is 0.5, I'm happy to say that this is against bacterial infection. Now, having a look at our viral serology. So with hepatitis A, your IgM being negative is against an acute infection. And the IgG is a marker that this patient has had infection before and is now immune for life. So regarding the Hep B serology, the fact that the hepatitis B surface antigen is negative is against an acute or chronic infection. The fact that the surface antibody is positive tells us that this patient is immune and protected. This could either be due to vaccine or previous exposure, which brings me to the next marker. The hepatitis B total core antibody is positive, indicating that this patient was previously infected and has been conferred immunity from that episode. And the hepatitis C IgM was negative, which is against an acute infection. So also just keep in mind that the CMV was also done. So now for some comic relief, we know the saying that a picture says 1,000 words. So in modern pop culture, a meme says 1,000 words. So here you have a physician ordering a battery of tests, and CMV is one of them as before. And you have your virologist going, why though? The virologist wants you to be mindful. He wants you to be a little bit more demure. So on that point, if we remember that CMV serology was requested, and if we remember and recall the profile of our patient, I'd like you to remember this mnemonic as a takeaway. So our patient was not immunocompromised, although she was senior in age. So not common etiologies of viral hepatitis. So the herpes family of viruses, they do not primarily target the liver. All of them can cause latent infection and reactivation, and this plays an important role in your immunocompromised group. So transplant patients, oncology patients, HIV-infected patients. So if we unpack them very quickly, your CMV can cause primary infection where you have an infectious mononucleolus-like picture with some pharyngitis, lymphadenopathy. It can cause hepatosplenomegaly, and it's really in your immunosuppressed group that it can cause disseminated disease and more severe infection. And in HIV-positive patients, it can mimic PSC. So with EBV, it's often asymptomatic. Again, it causes infectious mononucleosis, so fever, pharyngitis, lymphadenopathy, and most adults, over 90%, would be infected and immune come the 5th decade of life. So again, usually mild and self-limiting disease, and hepatitis is said to occur in less than 1% of patients. And I included varicella zoster that causes chickenpox and herpes zoster and herpes simplex, because if at all you are suspecting herpes simplex, treatment should be started upon the slightest suspicion, because it can cause a very fulminant hepatitis, and you would even want to start treatment while you wait for results of your laboratory testing. And while disease can be mild, you want to look for lesions like your vesicular rash. It can be oral or genital. However, markers for more severe disease is pregnancy, a positive PCR, thrombocytopenia, impaired liver function, and actually the absence of skin lesions. So now I'm going to also give you a little tip about interpreting serology. And for those of you, your Weakest Link fans out there, this is for you. So true or false? Whose liver has failed the LFTs? Didn't do a very good job of mimicking Anne. So general principles to remember with your serological test interpretation. When you get a positive, ask yourself, is this a true positive? Because there are many other entities that can contribute to cross-reacting antibodies and give you a false positive. So other chronic liver disease or hepatic disease, connective tissue diseases, other viral infections, pregnancy can give you false positive serology results. Remember that your serological tests are dependent on a functioning and robust immune system. So if your patient is immunocompromised, they may not be able to mount that response to generate the positive that the test is trying to measure. Disease stage is important. If we take hepatitis A, for example, it's fecal-oral spread, so maybe other members of the household had it, from drinking the same water or food, and you wonder why maybe the lab gave you a negative. So if it's very early in the disease, you may have to repeat your serological test to allow time for that seroconversion to occur. So another thing is specificity, in bearing in mind that there are false positives and cross-reactivity. Is it wise to do a PCR? Do I need to consider a viral load? In certain cases, you may need to consider avidity, not necessarily specific to this context. So in short, if the shoe fits, and that is you combining your lab indices, your radiological indices, and your clinical findings and history to make your decision. And then just a closing point from me to touch on autoimmune hepatitis. So as my colleague alluded to, it does occur more in females. However, any age can be affected. It varies in its severity from mild to fulminant. It's variable in nature from being acute to chronic. They can be, and it's important to screen in your history for concurrent autoimmune diseases, of course, including SLE, rheumatoid arthritis, and autoimmune thyroiditis, to correlate with your clinical findings. Is there other perhaps joint pain or there's numerous factors to consider. And with your lab findings, I always struggle to remember the battery of autoantibodies to remember these niche tests. And so at the top, you have a little boy with asthma, so your anti-smooth muscle antibodies. In the middle, you have a spiritual teacher from India, and her name is Amma. Also in the Tamil vernacular, which I'm sure many of our KZN colleagues are aware, Amma means mother, and so anti-mitochondrial antibodies, and at the bottom we have Queen Anna or Queen Anne, and so you have anti-nuclear antibodies, and there's also anti-DNA. Also your serum globulins would be important, and of course histology, and important to note, you should exclude other forms of chronic liver disease before you make this diagnosis, or liver disease. So back to you, Davina.
Thank you, Shaylin. So, with regards to this case, the physician, on inquiry by myself, stated that on the initial presentation, the patient had had gallstones which were retrieved via ERCP, Domia basket on the ERCP. He also had started the patient on prednisone for something he queried, which could have been autoimmune hepatitis. However, the patient unfortunately presented 3 weeks later, once again with deranged LFTs similar to her first admission, although the values were slightly lower in terms of the liver enzymes. She had similar signs and symptoms as initial admission, and the patient now verbalized that she suspected herself of being poisoned by her partner. Remember, she was 82 years old. The physician did indulge her and did a heavy metal screen, and the heavy metal screen were negative except for arsenic, and the levels were significantly elevated. The level of arsenic was 62 micrograms per gram, and the reference range is less than 15 micrograms per gram. Another way of putting this is that the biological exposure indices in the absence of seafood for 2 days is 35 micrograms per liter. Hers was 86 micrograms per liter. And this is because seafood has minute quantities of heavy metals, including arsenic. She also exhibited signs of hepatic encephalopathy on the second admission with a hyperammonemia of 102, which was significant. This patient was then treated once again symptomatically and supportively and chelated for the heavy metal toxicity. And just as an aside, when she relocated to her daughter as an outpatient, her arsenic levels fell to the normal range. On further investigation, it was found that the patient lived on a farm in Richmond, and there was possible groundwater contamination of the borehole water she was drinking. Testing of the water and her cohabitant in the house was going to occur. Our specialist esoteric pathologists were also consulted on this case, and they did remark that in cases of deliberate poisoning, the levels of arsenic are usually many times the upper limit of normal, and this is more in keeping with environmental contamination. On further inquiry, the patient revealed that surreptitiously she had been taking macrodantin or nitrofurantoin for recurrent UTIs that she had had from her GP long ago. The physician therefore made an assessment of nitrofurantoin-induced liver injury exacerbated by chronic arsenic exposure. A liver biopsy was considered as an outpatient, but because the patient had improved clinically, a biopsy was declined in view of her age. So it's just an aside to remember that, as much as we joke about these things, chronic arsenic toxicity is a reality in today's world. If we had to look at arsenic and the liver, in certain parts of the world, example West India, arsenic-contaminated groundwater is a reality, and moderate to high levels can cause liver injury, presenting sometimes long after exposure. In the acute sense, like in this patient, one experiences abdominal pain, diarrhea, and vomiting, and if the levels are high enough, coma and death. In the chronic sense, the high arsenic levels is carcinogenic, contributing to cancer, cardiovascular disease, diabetes, neuropathies. Remember, this patient had peripheral neuropathy, liver disease, ocular disease, and skin lesions. Prolonged ingestion leads to accumulation in the liver, renal system, lungs, and other organs. And I'd like to remind you that this patient presented with dyspnea on presentation. Chronic exposure leads to hepatomegaly, hepatoportal sclerosis with portal hypertension, liver fibrosis, and cirrhosis. So on LFTs, one would find an increase in the bilirubin, transaminases, and alk-phos. Hematological abnormalities include anemia and thrombocytopenia, and on presentation, this patient did have a thrombocytopenia. Of note is the increased incidence of autoimmune disorders. Increase in the anti-nuclear antibody is very common, and not always, but sometimes you get an increase in the anti-double-stranded DNA. And the mechanism of injury is that there's tissue injury and uncoupling of oxidative phosphorylation and inhibition of enzymes at a cellular level. The treatment of arsenic poisoning, whether it acute or chronic, includes chelation with dimercaprol and to eliminate the source, as this patient did when she went to live with her daughter. With regards to nitrofurantoin or macrodantin in the liver, it can be used as a first-line treatment for uncomplicated cystitis, as well as prophylaxis for recurrent cystitis. This patient had had 2 bouts of cystitis for which she had been using the macrodantin. The adverse effects of macrodantin or nitrofurantoin include peripheral neuropathy, pulmonary toxicity once again, hepatotoxicity as well, which may be fatal. This drug as well may present days to weeks after treatment initiation. In these cases, hepatocellular enzyme and bilirubin elevation is found, as in this patient, fever, abdominal pain, nausea, and malaise. This drug as well increases your anti-nuclear antibodies and your anti-smooth muscle antibodies, mimicking autoimmune hepatitis. One also gets an immune thrombocytopenia in these idiosyncratic drug reactions. The risk factors for hepatotoxicity include an older female and prolonged use. So according to the EDL, the treatment dose is 100 milligrams BD for 5 to 7 days, and the prophylaxis dose is 50 to 100 milligrams daily for 6 months. Some of the patients do confuse the two and take the treatment dose as a prophylactic dose, so a higher BD dose for 6 months. If a patient is on prophylaxis, one should remember to monitor the LFTs a month after initiation and there every 3 months and discontinue with liver enzyme elevation. Thankfully, the hepatotoxicity is reversible after stopping, and one should not think of re-challenging the patient. Just as an aside, with regards to arsenic toxicity, the arsenic induces the autoimmune damage, and so one often finds that there's no improvement in the anti-nuclear antibodies even with time because of the autoimmune induction. So at this point, I'd like to give you an approach to an abnormal LFT because it's like a minefield. The important thing is on history. As for example, this particular case, the patient only came out with the history of querying being poisoned and taking the macrodantin much late into her disease progression. But it's so important to identify the risk factors for liver disease, exposure to hepatotoxins. Hepatotoxins we often dismiss, alcohol, medications, and symptomatology. On history, one should look for any symptom of a predisposing condition, any autoimmune conditions, or systemic illness or risk factors for viral hepatitis. For example, a previous blood transfusion in the case of Hep C, or gastroenteritis symptoms for Hep A. On physical exam, one should look for signs and stigmata of liver disease, for example, your spider nevi, your caput medusae, etc. A very good mnemonic is from the American family physician and taught to me by Dr. John Hein Knoblauch, and I just find that there are many calls from GPs about a slightly aberrant LFT, and they don't know what to do next. But a very useful tool is the ABCs, where A stands for autoimmune hepatitis or hepatitis A, B for Hep B, C for Hep C, D for drugs and toxins, and I think the drugs and toxins is something not to be overlooked as mentioned, E for ethanol or alcohol, F for fatty liver, and this includes your non-alcoholic steatohepatitis, and so your non-alcoholic fatty liver disease, including NASH. Your G is for growths or tumors. H is for hemodynamics, example CCF. I is for iron, which includes hemochromatosis, copper deposition in Wilson's disease, alpha-1 antitrypsin deficiency, and other infections. So I also stands for other infections. And M is for muscle injury, because with muscle injury, you can find an increase in your CK and an increase in your transaminases, mimicking a hepatitic picture. The pattern of the liver test abnormality is also important. Is it acute, subacute, or chronic? Our patient was acute, being less than 6 weeks of duration. There you'd consider acute hepatitis and toxins and drugs. Subacute, 6 weeks to 6 months, one could still consider drug use there. Chronic, more than 6 months, one would think of chronic Hep B, Hep C. And also the pattern of elevation would point you as to the etiology. Is this an isolated hyperbilirubinemia? Is this a cholestatic picture? Is this a hepatocellular picture or hepatic picture, or is it a mixed picture? Cholestatic obviously would point to your surgical or your deep jaundice, your obstructive causes. So somehow the predominant abnormality when you look at an LFT doesn't always jump at you. And even to a ChemPath, it's not always obvious. So an interesting equation is the R value, where you take the ALT over the upper limit of the ALT and divide it by your ALK phos over your upper limit of your ALK phos. And if it's more than 5, it points you to hepatocellular injury. So that is your hepatocytes being affected, so hepatic causes. Between 2 and 5 is a mixed picture, and less than 2 is more a cholestatic injury or an obstructive picture. In this case, her value worked out to 10, so she was definitely in the realm of a hepatitic picture. So we can also use the transaminases to point us to the etiology. In the realm of cirrhosis, one would find, or chronic liver disease, low-lying levels of your transaminases. Your chronic hepatitis, it climbs up a bit more to about 100 units per liter. And you can see in this patient, she was 300 to 1,000 units per liter. So there's a crossover between alcoholic hepatitis, acute viral hepatitis, and toxic or ischemic injury. So it crosses all three. As mentioned before, the low upper, more than 2 times upper limit of normal, one would think of chronic Hep B and chronic Hep C. Around 4 times upper limit of normal and less than would include things like non-alcoholic fatty liver disease, which is very common these days with the metabolic syndrome being prevalent, obesity, and then you'll find a mild increase in your transaminases, your ALT and your gamma GT, and then you'll do an ultrasound to look for fatty liver disease. 5 times upper limit of normal, it's could be a whole host of things, including infection, alcohol, fatty liver disease, medication, many medications, over the counter as well as supplements, and Ayurvedic medication can cause an increase in your liver, your transaminases. Unusual causes include thyroid disease and celiac disease. A thing to remember is that AST to ALT ratio more than 2 points to alcoholic hepatitis, because the ratio is usually ALT to AST around 1.5, and this is maintained even in fatty liver disease. More than 10 times upper limit of normal, this is pointing to an acute or severe insult, and this is where our patient was sitting. This could be due to drug-induced toxicity, acute viral hepatitis, hypoxia, or exacerbations of chronic hepatitis. So that's an acute on a chronic picture. More than 25 times upper limit of normal could point to acute viral hepatitis or a toxin-related hepatitis. And more than 50 times is if there's a thromboembolic event to the liver causing an ischemic hepatitis with necrosis of the hepatocytes. So I'd just like to please at this point bring in my colleague once again to discuss the use of macrodantin, because this is an important drug in the armamentarium against UTIs. And I'd like him to discuss the use of nitrofurantoin and the idiosyncratic drug reactions. Thank you.
Thank you, Davina. So nitrofurantoin is a broad-spectrum agent. It has cover against gram-positives as well as gram-negative bacteria, and it is used for uncomplicated UTIs. It concentrates very well in the urine and has low serum concentrations, which, equips it to be very well used for its purpose in the treatment of uncomplicated UTIs. And in it being restricted to the lower urinary tract, it wouldn't affect bowel flora, which is very important if you think of things like C. diff using other agents. Side effects are actually typically mild if they occur, especially if you contrast them with agents like ciprofloxacin and cotrimoxazole or Bactrim for the same purpose. So I hope that this won't deter you from its use. It is endorsed by the IDSA, the American Disease Society of America, for its use in uncomplicated UTIs, and especially in the age we're in of multi-drug resistance. There's very high rates of CRE now, carbapenem-resistant Enterobacterales and ESBL-producing organisms. It's a perfectly good choice to use for uncomplicated cystitis or UTIs. This patient, unfortunately, several elements came together to create the perfect storm for toxicity to occur. It was used more consistently and for prophylaxis as opposed to its usual purpose for a limited amount of time for uncomplicated UTIs. So thank you.
Thank you so much, Shaylin. And also just to remember that the increase in ANA and anti-smooth muscle antibodies, as we said, is pathognomonic of your autoimmune hepatitis. But it can also, you can have an increase in your ANA in viral infections, bacterial infections, older age, tissue damage, example in drug toxicity, or with regards to arsenic toxicity. And so it's fairly non-specific. AMPATH does offer a liver blot or a liver line immunoassay, which include things like the LKM antibodies. So if in doubt, I would also encourage the use of the liver blot, because seeing that some of these tests are fairly non-specific and one wants to hone in on the diagnosis. The other thing I'd like to encourage is the use of a pharmacogenomics profile, because as Dr. Shaylin Pillay mentioned, this patient had an idiosyncratic drug reaction because the drug is fairly safely used in most instances. However, this patient had adverse effects. Our pharmacogenomics profile basically will predict the adverse reactions a patient can have prophylactically, and sometimes a doctor can use it reactively once the patient has had the reaction to see if that actually was the cause of the drug reaction. Okay. Sorry. So the take-home points, and I'll just say my points, and then Dr. Shaylin can bring in his points, is that history guides the judicious use of the laboratory in the patient's best interests, and probing regarding medication or toxin exposure is sometimes required by the clinician. Signs and symptoms clinical exam is vitally important to corroborate with the lab findings. And drugs and toxins are an important cause of hepatitis. It's not always infectious in nature as an etiology. The liver is a sensitive indicator of systemic pathology, and it can be considered a harbinger of disease, as it is the seat of metabolic processes in the body. Doctor.
Thank you. So yes, nitrofurantoin is an IDSA recommended first-line agent for uncomplicated UTIs. Side effects for therapeutic or short-term use, if any, are typically mild and self-limiting. In the years of experience I've had in my micro training and practice, I've not come across a case like this before, nor do I know of colleagues who have. So typically, it's the prophylactic and longer use combined with other patient factors that may contribute to toxicity. And certainly in those cases, precautions in monitoring should be taken. Thank you.